hiện những cái mới thì cái cơ bản của chúng ta vẫn là hỏi bệnh sử và khám lâm sàng của bệnh nhân bị MS. Thank you so much, Professor Noriko Isobe, and I wish you a very happy Christmas with your family and all your team.
Thank you.
Okay.
You too. Thank you.
Thank you. Bye. Okay. Xin mời tiến sĩ Đinh Hiếu Hùng qua phần giới thiệu cho giáo sư Tuấn Vũ ạ.
Dạ, em xin cảm ơn thầy rất nhiều ạ. Kính thưa tất cả các anh chị đồng nghiệp, để tiếp tục bài báo cáo trong chương trình hôm nay, sau đây tôi xin được phép chia sẻ một số thông tin về giáo sư Tuấn Vũ đến từ Hoa Kỳ. Giáo sư Tuấn Vũ là giáo sư thần kinh học và là trưởng đơn vị thần kinh cơ, phòng điện cơ, phòng khám chuyên khoa về ALS tại trường Đại học Y khoa Myasthenia thuộc Đại học Nam Florida. Giáo sư Tuấn Vũ là một chuyên gia nghiên cứu về nhược cơ và các rối loạn thần kinh cơ khác, đặc biệt là lĩnh vực về thử nghiệm lâm sàng. Giáo sư Tuấn Vũ học nội trú thần kinh, học chuyên sâu điện cơ và học thần kinh cơ tại Đại học Columbia ở New York. Hôm nay, giáo sư Tuấn Vũ sẽ trình bày trước hội nghị một chuyên đề rất hay và rất có ý nghĩa trên thực tiễn lâm sàng, đó là cập nhật chẩn đoán và điều trị nhược cơ. Xin trân trọng kính mời giáo sư.
Xin cảm ơn anh. Tôi xin cảm ơn bác sĩ Hùng đã cho tôi cơ hội này để trình bày về Myasthenia Gravis. Vì tôi không có rành cái danh từ y khoa Việt Nam nên xin nói cái bài này bằng tiếng Anh.
Dạ không sao anh Vũ. có thông gì ạ?
Can you see my screen?
Yeah, very good.
Okay. So I'm going to talk to you about Myasthenia Gravis and the newer drugs that are coming out.
Recording stopped.
And so here's my conflict disclosure. I'm the site principal investigators for a lot of the MG trials.
Recording in progress.
And I also do consultation for Electron Argenx. So for today's talk, I'm going to talk about the clinical features of Myasthenia Gravis. We'll describe the basic disease pathogenesis in terms of activation of the complement cascade. We'll talk about the new drugs mechanism of action, in terms of complement and the FcRn blockade. And I'll talk about the clinical trials data that show the efficacy of the emergent treatment in Myasthenia Gravis. So as you know, Myasthenia Gravis is a antibody-mediated autoimmune disorder. In MG, the autoantibodies target the neuromuscular junction here and leading to impaired neurosynaptic transmission and subsequent fatigable muscle weakness. So the weakness in MG is interesting in the sense that when you test a patient, you may not detect any, but if the patient is exercising more and more, the weakness may come out, and that's what we refer to as fatigable muscle weakness. They usually start out with having ocular symptoms. So these are the patients that come in with droopy eyelids and seeing double. And then about 75% of them actually progress to have generalized weakness. And you can see that in the bulbar function. So they have trouble with speaking, swallowing, and they may have trouble with facial weakness as well. They may have head drop because of the neck weakness. They may have trouble breathing, whether by exercise or lying down. And they may not able to generate a good cough because of the weakness of the muscle respiration, and that predisposes them to pneumonia. And of course, they can have proximal limb weakness, predominantly in the shoulder or hip girdles, but you also find finger extensor weakness as well. So the problems start out in the thymus. So in a healthy situation, the thymus is where the T cells go to differentiate. And if they start to react against your own body, they get eliminated really quickly, and that's negative selection. In Myasthenia gravis and many other autoimmune disorder, these autoreactive T cells, T cells that direct against yourself, are not eliminated and get released. And in fact, in MG patient, we find that in 80% of them, they do have thymic abnormalities like thymomas in about 10 to 30%. So these autoreactive T cells go out or stay in the thymus and activate the B cells. The B cell then transform into the plasma cells. The plasma cell then create these antibodies. And there are several types in Myasthenia gravis. 85% of them, of the cases, they're directed against the acetylcholine receptor, about 8% against the so-called muscle-specific kinase, 5% against the LRP4, and then about 2% the voltage-gated calcium channel presynaptically. So here are the functions of these proteins. So the acetylcholine receptors sit in the postsynaptic membrane, and when the acetylcholine molecule hit it, then you have end plate potentials, and if there's enough of them, then you have muscle membrane depolarization and muscle contraction. The MuSC play a role in the formation of the neuromuscular junction and assembly of the receptor together. The LRP4 complex bind the agrin and cluster the receptor together so they become more efficient. So what happened is when these antibodies bind against these proteins, is disrupt their function, and as a result, neuromuscular transmission doesn't occur, and therefore your muscle don't contract, and therefore you have muscle weakness. In terms of the anti-acetylcholine receptor antibodies, there's actually 3 types. The most common is probably the binding type, and that's detected in about 70 to 80% of the patients of the generalized form, about 60% in the ocular form of MG. And this is the antibodies that actually activate the complement pathway, which I will talk in a moment. The modulating antibodies present about the same frequency as the binding, and they act through a different mechanism, as is the blocking. The striatal antibodies, sometimes we do, mainly because if they're present, then we need to look for thymomas because there's a strong association. In terms of the subclasses, so all these antibodies are IgG class. The anti-acetylcholine receptor antibodies are of the IgG1 and 3, and those are associated with complement activation. The LRP4 also activate complements, but not to the same degree. They're basically IgG1 and IgG2. The MuSC antibody is IgG4, and that does not have anything to do with the complement cascade at all. It acts by a different mechanism. So here's a complement cascade. This is how we fight encapsulated bacteria. So basically what it does is it drill a hole in the membrane through the formation of the membrane attacking complex and then cause cell lysis. I have a video here demonstrating the process of the complement cascade. I'm hoping that will come through. Ooh.
Myasthenia gravis, mechanism of disease. Myasthenia gravis is an autoimmune disorder characterized by neuromuscular transmission failure and subsequent voluntary muscle weakness. Antibodies bind to the acetylcholine receptors on the muscle end plate of the neuromuscular junction, causing muscle weakness via 3 mechanisms. First, via functional blockade of the acetylcholine receptor by interfering with binding of acetylcholine released at the neuromuscular junction. Second, by antibodies cross-linking acetylcholine receptors, leading to their absorption and ultimately their degradation, known as antigenic modulation. And third, by binding to the acetylcholine receptors and activating the complement cascade. To understand the pathogenesis of myasthenia gravis, it is vital to understand the role of complement in this disease, as complement may be one of the causes of acetylcholine receptor loss of function and the primary cause of the destruction of the normal morphology of the neuromuscular junction. The first step in the complement classical pathway is initiated by the binding of the C1q complement protein to the acetylcholine receptor autoantibody. The complement cascade then proceeds through a number of steps that ultimately results in the formation of the enzyme C5 convertase. C5 convertase acts on complement protein C5 to produce two fragments, C5a and C5b. C5b then binds with complement proteins C6, C7, C8, and multiple molecules of C9 to form the membrane attack complex. The membrane attack complex forms transmembrane pores in the muscle end plate, destroying the membrane and disrupting the morphology of the spine. In Myasthenia gravis, the postsynaptic regions disintegrate, shedding fragments coated with membrane attack complex into the synaptic space and reducing the number of junctional folds in the motor end plate. This destruction of the neuromuscular junction results in an overall decrease in the number of acetylcholine receptors, destroys the normal functioning of the neuromuscular junction, and results in the muscle weakness and fatigue observed in MG.
So here's the electron microscopy of a normal neuromuscular junction. You can see a lot of folds and in the postsynaptic membrane that basically increase the surface area and the number of receptors you can pack in a small space. And on the right, here's the same area from a patient with myasthenia gravis, where you see the folds are now all destroyed. And these black dots here are the deposit of C9, suggesting that the complement cascade had been activated and what's caused the damage. Electron microscopy of a normal neuromuscular junction. Just a quick note see a lot about the other proteins, the LRP4 in the muscle. So basically, they cluster the acetylcholine receptor together, and if you damage those proteins, that does not occur, and therefore the efficiency of neurosynaptic transmission is not as good, and therefore you get weaker because of that as well. If you want a guideline into how to treat myasthenia gravis with existing medication, I would suggest this particular article. It's free online, and it goes through the different drugs that we normally use. For the rest of this talk, I will talk about the newer drugs that's coming out. So before I do that, I want to talk about two measures that we use in clinical trials to determine whether a drug works or not. So the American FDA, the Federal Drug Administration, wanted to have a measure that reflect the patient experience. So for most studies, they insist on having us using this scale, the MG-ADL, activities of daily living. And basically, it's an 8-item questionnaire where you ask the patient how they do in terms of different things that they do during the day: talking, chewing, swallowing, breathing, moving their arms and legs, seeing. And the scale goes from 0 to 3. So 0 is normal, 3 is most severe, and you can score up to 24. And that's the thing about measure we use in MG trials. The higher you are, the worse you're off. So you want to be a 0. So that's the ADL score, and that's patient reported. So that's what the patient tells you. We use the quantitative Mg scale as well. This is what you do. So, you ask them to look to the right or the left and count up how many seconds it takes for them to get double vision. Or you can ask them how long they can hold up their arms or their legs or their neck, and how much air they can breathe out using a spirometry. This takes about half an hour, so it's kind of involving. Again, 0 is normal, 39 is almost dead. So in terms of inhibitors of complement cascade, there are a couple of drugs out there. So this one has been out since 2017. And in this study, the REGAIN study, we test patients with placebo, and here's basically what we did. We take 170 patients, screen them, and then 126 of them were eligible. And then we split them into two groups, one treated with drug, the other one treated with placebo. And after 26 weeks, we see how they do. And basically, this is the ADL score that I mentioned earlier. The top line is the placebo patients. So in every MG trial, there's going to be some placebo effect. And you know, we don't know exactly why, but in these trial, patients in placebo do get better. But the treated group, the group that got treated with drugs actually did a lot better throughout all the measures. So this is the ADL, this is QMG, and we also use the composite and the quality of life measures here. And you can see that, you know, if you use something like modafinil or azathioprine, you may have to wait 6 months to see an effect. With this particular drug, you start to see a separation about 2 weeks out. So you know pretty quick how you know, whether they're going to respond or not. Here's a Christmas tree plot. So it goes up in terms of how much improvement you have. So here's 3 points and here's 8-point improvement. Again, you see a lot of placebo effect, but as you make the improvement more strict, you see that more patients on the treated group responded than the untreated group. And that's the ADL. This is the QMG, which is the more objective ones. So at the end of 26 weeks, we switch the placebo patient over to the real drug, and you can see that they all improve. And then that effect lasted a couple of years. So the effect is pretty durable. It doesn't go away after a while. The problem with this drug is that it has to be given by infusion IV every 2 weeks. So it's a little bit inconvenient. So Alexion came out with a new drug called Revoluzumab. And this is basically also a C5 inhibitor, but it's now given every 8 weeks or every 2 months. We just completed the study recently, and we're submitting a paper for publication. So same scenario where you randomize patients to 2 groups. Again, look at them for 6 months, and you see the similar benefit where there's placebo response, but the drug response is much better, and again, very quick, within 2 months, 2 weeks or so. There's another drug out there called zilucoplan. So the previous 2 medication I'm talking about is a monoclonal antibodies. This one is actually a peptide by a different company called Ra. And they just finished the phase 3. The phase 2 show very similar effect to the eculizumab and Revoluzumab. We just finished this study about 2 or 3 months ago, so we should have the result in the next maybe February or so. I'm going to switch and talk about neonatal Fc receptor, FcRn antagonists as the way of treating. So remember that your plasma cells produce these antibodies, and they keep on producing them. And if there's no way for you to remove them, pretty soon your blood vessel is going to be all clogged up with, you know, immunoglobulin. So the system has a way of, the body has a way of recycling these molecules. So what it does is, here's the lumen of the blood vessels. So these immunoglobulin get uptake into the endosome and then transport to the lysosome, where if they bind to the FcRn, then they get safe, and then they get put back into the circulation, recycling. If they don't bind to one of these receptors, they get broken down and discarded. So that's how your body removes these antibodies. So the idea here for drugs that we're testing is, what if we block these FcRn? If we block these FcRn with the drug, the free antibodies cannot be recycled, but rather get broken down and removed from the system. So you can think of this as plasma exchange, where you actually filter out the antibodies. So we finished this early last year, and published this in Lancet Neurology about 3 or 4 months ago. And basically what happened, again, you see the placebo response here. where a patient actually got better in terms of their function, but the treated group got a lot better. And the drug is giving every week for 4 weeks, and then they get a break. So at the end of the 4 weeks, you can see that the response is pretty remarkable. And then as the drug wears off, they become back to normal. So this is a situation where you actually have to, give the patient 4 weeks of treatment, let them rest for 4 weeks, and then repeat treatment. And you can see that, again, the improvement is seen in every scale that we used. Here's a Christmas tree plot again. At 2 points improvement, half of the placebo patient responded. But if you make the threshold or the bar higher, like 9 points, none of them on the placebos improve versus 14% on the treated group. And then there's other companies as well that's making similar products. So UCB is doing this drug called Revoluzumab. We call it Rosie for short. They did a phase 2 trial that showed some positive results. So we did a phase 3. We just finished with that about 2 months ago. And yesterday they came out with the news that the drug actually worked. But this was a news release, so we don't know the results. The actual data yet. We will publish that shortly. Another drug of similar mechanism of action, Nipocalimab, is from another pharmaceutical. Again, is also a anti-FcRn, and we're just starting that study right now. In terms of other drugs, rituximab has been used a lot in patients who don't respond to standard treatment. The trouble is there's not a lot of data suggesting that it's actually, work. So there's this study called Beat MG about 2 years ago that tests to see if patients who are on prednisone can reduce their doses if they're on rituximab as well. And the result was not, highly positive. They couldn't be sure that it works, but it may work. So we don't know. This is a study on intravenous immunoglobulin, which is used a lot in the US to rescue patients from exacerbation of crisis. You can see that here all the possible mechanism of action of IVIG. So it's a real broad spectrum kind of treatment. It's used a lot for rescue. We try to test to see if it can be used as maintenance therapy. And the study was completed about 3 years ago now. It did not work. Actually, the reduction is pretty good. It's almost 5-point reduction. The problem is the placebo group also did really well. So as a result, the difference between the treated and the placebo group was not statistically significant. So it's considered a failed study. So in conclusions, there are several drugs that are under development for the treatment of MG. These drugs, either via complement cascade blockage or removing the antibodies from the system, seem to protect the neuromuscular junction, and the drugs seem to be working based on our studies so far. And so I'll end my talk right there and be glad to answer any questions that you may have. Thank you.
Cảm ơn giáo sư Tuấn Vũ rất nhiều đã trình bày cho chúng ta một cái chủ đề rất là hay, và chúng tôi nghĩ là cái chủ đề này rất cân bằng với lại những cái nội dung của hội nghị quốc tế trong 2 ngày vừa qua, bởi vì chúng ta đã có rất nhiều đề tài về đột quỵ, là một cái mảng mà rất nhiều các đồng nghiệp tham gia, thì chúng ta sẽ phải cân bằng bằng những cái chuyên khoa khác để chúng ta cho thấy được là cái ngành cái chuyên khoa thần kinh có rất nhiều cái đặc điểm khác biệt so với những cái bệnh lý về mạch máu. Thì một lần nữa chúng tôi xin cảm ơn giáo sư Tuấn Vũ rất nhiều. Xin phép tôi được nói một tiếng Việt là bởi vì giáo sư Tuấn Vũ thì nghe tiếng Việt rất tốt, nghe tiếng Việt rất tốt. Vâng. Thì
nói không được thôi nhưng mà nghe được.
Cảm ơn anh rất nhiều. Nếu trong trường hợp mà kỳ tới mà chúng tôi tổ chức hội nghị quốc tế tại Việt Nam thì chúng tôi sẽ cố gắng để tổ chức tại Nha Trang, là quê của anh. Vâng, để có gì là tạo điều kiện cho anh về thăm quê nhà, cũng như là về đóng góp những nghiên cứu khoa học của anh cho cộng đồng bác sĩ thần kinh của Việt Nam, và đặc biệt là miền Trung của giáo sư Tuấn Vũ. thì xin phép hỏi là tất cả các cửa tọa có câu hỏi nào đây là thì gửi đến cho giáo sư Tuấn Vũ, thì xin truyền tải đến đây, có thể nói bằng tiếng Việt, có thể nói bằng tiếng Anh cũng được, và nếu nói bằng tiếng Việt thì có bác sĩ Minh An xin dịch dùng. Thế thì xin mời, trước hết là xin mời những chuyên ngành của mình trong hội thần kinh, ví dụ như là tiến sĩ Lê Từ Quốc Tuấn hay là phó giáo sư Nguyễn Hữu Công, nếu có mặt ngày hôm nay thì có thể đặt câu hỏi cho giáo sư Tuấn Vũ ạ. Và nếu mà có anh em nào khác cũng vẫn được ạ. Xin mời quý vị ạ. Vì giáo sư Tuấn Vũ là Việt kiều đồng hương, chúng ta sẽ có 10 phút. Tức là gấp đôi thời gian để mà trao đổi. Anh chị em có ý kiến gì không ạ?
Gọi nói bằng cái này đi, cái kia để bật học online.
Có nghe nói có hai câu, thấy trong có hai câu hỏi là thứ nhất là what's your experience with ocular MG treatment is actually pretty tough. Ocular myasthenia gravis, ocular symptoms are the first to come on and the last to go away. So, and it's one of those things that you have to be perfect. So if you see your image like this and you get it like this, you're doing a lot better, but it's not perfect and you still see double. So it's Eculizumab works reasonably well, except that extraordinarily expensive for that purpose. People use steroids a lot, but then steroids have long-term side effects. The second question is, do you screen antibody for MG patient? Yeah, we do. And sometimes, the first time we screen it, it'll be negative because it may be early in disease. And sometimes we if it's negative in the first place, we screen again a year later to see.
Okay.
And it's very lab dependent too. Some of the labs are not that reliable.
Okay. Thank you so much. Các quý vị có ý kiến gì khác không ạ? Bác sĩ Minh Đức hay là bác sĩ có ý kiến gì không ạ? Vâng, thưa giáo sư. Vâng, mời anh Thông ạ.
Vâng. Tôi xin rất cảm ơn cái báo cáo rất là hay. Nhưng tôi muốn hỏi một câu, giáo sư Tuấn Vũ. Ngoài những thuốc chế miễn dịch anh vừa nêu trong bệnh liệt cơ rồi thì cái vai trò của phẫu thuật đến Đức hiện nay thì như thế nào? Xin anh cho ý kiến thêm ạ. Vâng, cảm ơn.
Thưa giáo sư Thông là chủ tịch hội đột quỵ của Việt Nam ạ. Là một người rất là làm rất là chuyên lâu trong cái ngành đột quỵ. Vâng.
Xin hỏi lại câu hỏi.
Dạ, thưa về vai trò của mổ phẫu thuật tuyến ức ạ. Phẫu thuật tuyến ức tức là
so, they improve in terms of how much medication they need. They improve in terms of their function. So it's recommended. The trouble with thymectomy is that you have to make sure that in the adults, it's not a gland like this. It's actually spread out. So you have to make sure that you remove every single piece. I have patients that the surgeon left a small piece in there and they continue to have symptoms years after.
Okay.
So in the old days, when I first started out, everybody suggested you open the chest up, to make sure that you look and move everything. Nowadays, the endoscopy is good enough that most people don't do that anymore.
So that in US, you can also not remove all of the thymus.
Yeah, because if you do a scope, it's not a gland like this where you come in and just plug it out.
Very small.
It's spread out like this. So if you don't go and open and remove everything, it may not do you any good.
Thank you. So, cảm ơn giáo sư Tuấn Vũ rất nhiều. Các đồng nghiệp còn ý kiến gì được không ạ? Đây là một dịp rất là hiếm và giáo sư Tuấn Vũ có thời giờ để trao đổi với chúng ta và cho chúng ta những kinh nghiệm rất quý giá. Thưa, nếu mà không có ý kiến gì nữa thì xin cảm ơn giáo sư Tuấn Vũ rất nhiều. Hẹn giáo sư Tuấn Vũ gặp một dịp trong hội nghị tại Việt Nam Và lần này thì chắc chúng tôi phải mời giáo sư Tân Vũ đi thăm 3 miền luôn, miền Trung, miền Bắc và miền Nam, để biết Hà Nội, Nha Trang và thành phố Hồ Chí Minh, Sài Gòn.
Cảm ơn.
Cảm ơn. Xin cảm ơn. Thank you so much for your presentation, and I very appreciate so much your working, hard working to conduct the research and also the treatment for myasthenia patients. Thank you so much. Okay. Cảm ơn anh. Xin mời bác sĩ Minh Đức ạ.
Tất cả thì tiếp theo là giáo sư người đất Ấn, Janaswamy Venkatasubrahmanyani. He Gravis as fast no Ocean Center in Singapore. He was a senior consultant in the division of Gravis at the National University Hospital. He was also associate professor with the Department of Medicine and the Department of Immunology and Public Health and Journalism in India. His major interest in stroke, neurology, epidemiology, and clinical trials. I want to. I would like Dr. Romani. I would like you to present energy factor of focus.
Good morning. Good morning, everyone. Thank you for inviting me. Hello, Prof. Hung. Thank you very much. It's very nice of you to invite. I'm happy to join you today at your exciting conference. I heard the other speakers. I learned so much from them. I'm happy to share some things with you all on emerging risk factors for stroke. So shall I share my screen from my side, or will you move from your side?
Thank you.
Some emerging risk factors for stroke. I know many of you will treat stroke in your clinical practice, and we know the common ones, but there are some which we may forget. So I thought I'll share some of these with you, which are now becoming more and more important. I will discuss the A to Z of the common risk factors. There are some that are emerging that start with I, U, and X, which I'll share with you before making some concluding remarks. We know stroke is a major cause of death and disability in most of the world, including Asia Pacific and in Vietnam. We also know some things we cannot change that raises stroke risk: being older, being a male, having a young family member with stroke, genetics like CADASIL, in ethnicity like American blacks, all have a high risk factor for stroke, and we cannot change these risk factors. But there are some very modified of all the important risk factors: atrial fibrillation, hypertension, cigarette smoking, diabetes, too much alcohol, being overweight, genetics including CADASIL, and other genetic risk factors, young stroke, hormones, contraceptive pills, and hormone reduction therapy. I'll discuss this secret in a few minutes. Taking illicit drugs such as cocaine, carotid stenosis can raise stroke risk. Hyperlipidemia, including Lp(a), migraine, especially migraine with aura, and in those who smoke. Being overweight or underweight, sleep apnea, procardial states, protein C, protein S, homocystinemia, cardiac disease, including rheumatic heart disease, vasculitis. Sickle cell can also damage the brain vessels and cause stroke. We know previous TIA and stroke before. I'll discuss you shortly. Vascular disease in the legs also raises stroke risk. Getting older, like me, is one. I'm not as young as Dr. Hung, as you can see, always looking young forever. The X factor, being a male and having a very sedentary life with no exercise. So let me now discuss the I and the U and the X, because everything else you already know. I stands for infections, inflammation. These can cause stroke directly. Infective endocarditis can cause a infected thrombus to go to the brain. Infections of the meninges, tuberculosis, cryptococcosis, and other infections of the meninges, meningitis can cause occlusion of small arteries in the brain and cause stroke. Inflammation from herpes, HIV can also affect the brain arteries. But I won't discuss this. I'll discuss this often forgotten stroke risk factors from acute and chronic infections that causing inflammation can cause acute stroke by making atherosclerosis more quick and altering the coagulation pathways and atherogenesis. So I, for acute infection. Having an infection raises a stroke risk. In the first week of any infection, the risk of stroke goes up by 4.6 times, especially if there's fever, there's respiratory, and a bacteria like pneumococcus, H. influenzae. These infections of the lung can raise the stroke risk by 4 to 6 times. What type of stroke becomes more frequent is atherothrombotic stroke, 5.7 times, and cardioembolic stroke by 3 times. So acute infection, especially respiratory, bacterial, can increase the risk of ischemic stroke. Other infections too. For example, influenza also raises stroke risk. How does influenza and other infections raise the risk of stroke? Well, we think it's because of induction of procoagulant states, like making more fibrinogen or destabilizing plaques that are already there. So these are the mechanisms by which infection can cause stroke. Interestingly, if they stay in hospital for too long, being in hospital also raises the risk of stroke. So being in hospital is not a good thing for many people, unfortunately. Can we prevent stroke from infection? Those who have no infection yet, does giving antibiotics help? Unfortunately, no. Many randomized trials of antibiotic therapy do not prevent cardiovascular points, including stroke. But there is something we need to recognize from this. Treating with a viral agent does make a difference. Treating influenza with an antiviral medication can reduce the risk of stroke by 28%. Vaccination can also reduce risk of stroke in a case control and a cohort study. In fact, in Taiwan, vaccinating people above 65 years old reduced mortality and stroke by nearly 65%. So treating influenza can prevent stroke. Vaccinating against influenza also prevents stroke. Here's a meta-analysis showing overall that vaccination can reduce stroke risk by up to 18% when you pool the results of all the trials. So clearly vaccinating can prevent influenza, can also prevent stroke. I is for acute infection, I also for chronic infection. Infections and together with other host factors, hypertension, diabetes, cholesterol, smoking, other risk factors, raise the risk of atherosclerotic stroke. So it is believed that all this, by promoting atherosclerosis, raise the risk of stroke in people who have any of these chronic infections. Individually, it doesn't seem to make a big difference, but when you combine them together, the inflammatory burden increases by 1.39 times if there is chronic infection. So having chronic infection in combination especially raises the risk of stroke, even though you adjust for age, gender, education, and other risk factors. So chronic infection alone can reduce stroke risk, not just acute, but also chronic infection. One example is chlamydia, the best studied. In this, whether IgG for chlamydia is high or IgA, overall the risk of stroke is increased by about 1.6 times or up to 2.3 times. The strongest association is with atherothrombotic stroke, not cardioembolic, not lacunar, but atherothrombotic stroke. the next I is for inflammation. I for acute infection, I for chronic infection, I for inflammation. Inflammatory mechanisms have a big part to play in starting and progressing atherosclerosis. So this is not due just to hypertension, diabetes, risk. Inflammation itself can raise the prothrombotic factors. So these are various ways by which acute and chronic inflammation lead to stroke. A number of markers of inflammation: CRP, fibrinogen, amyloid A, LPA2, interleukin-6, and so many others. Some of these are available in many labs routinely. Overall, CRP increase the risk of mortality, but not stroke individually. Ischemic stroke, no big difference, as you can see, in control versus inflammation. Heart attack, yes, a higher risk. When a sub-analysis was done, CRP was associated with cardioembolic stroke. So possibly high CRP, which is chronic inflammation, causes myocardial infarction that then leads to cardioembolic stroke. And that is how CRP is probably linked with ischemic stroke, by causing more cardioembolism. Can we prevent stroke in those of high inflammatory burden? Let me share the Jupiter trial. In the Jupiter trial was a randomized trial of statin versus placebo using rosuvastatin in those who had no coronary artery disease, but had normal cholesterol levels, but high CRP. The study found that they could, by giving Crestor, they could reduce cardiovascular endpoints, including stroke, by up to 48% by giving statin to those at high CRP levels. So what do the guidelines say? The guidelines say that from this information, that giving vaccination can reduce the risk of stroke in those who have stroke, who don't have stroke yet. And treating influenza can reduce risk of stroke also in those who have influenza. Measuring inflammatory markers may be useful to find out those at risk of stroke. But for those at high CRP and no other stroke risk factor, maybe giving a statin can reduce the risk of stroke. However, giving antibiotics is not recommended to reduce the risk of stroke in individuals. So we discussed the I: acute infection, chronic infection, and inflammation. Let me move now to the U factor. What is the U factor all about? The U factor is unhealthy air, air pollution. So much we're seeing of air pollution now in many parts of the world. Air pollution occurs when harmful or excessive amount of substances, be it gases, small particles, or molecules, enter the atmosphere. These particles cause many diseases, cause allergies, and even death. Not just to humans, but to other things. Animals die. Our pet dogs, our pet birds, our pet cats, our cows, and all are dying from stroke. And the crops we plant, rice, all die from pollution as well. And this pollution damages the natural environment we live in, the forests, our lakes, and damages our buildings. So pollution really does a lot of bad things. But it's true that pollution can occur naturally and also by things which we do. We ourselves can create air pollution. What are natural things? Volcanoes erupt, forest fires occur. There also are thunderstorms. These produce natural pollutants. But sadly, we humans also make pollutants by burning our fires and burning our crop areas, incinerating rubbish, our cars and trucks and aeroplanes, our factories, burning our fuel, using things like aircon refrigerants, metals, all these are polluting the air. So these are primary pollutants. When these pollutants mix with particles like ozone and smog, they cause further pollution. So primary and secondary pollution are all bad. And the pollutants could be small particles or could be gases. Whatever they are all bad news for stroke. Burning our petrol from power plants and from heating the homes and other places. Then the very, very fine particles, the ultra fine nanoparticles that come from our vehicles, especially from diesel. All these are particles that are bad for health. If you look at this meta-analysis, where there's pollution, there is stroke. So air pollution and stroke are very strongly linked in these countries, and the data is very clear about this. Which particles are important? Carbon monoxide overall, yes, especially in the early phases after exposure. Sulfur dioxide, yes, again, in the early phase. Nitrous oxide, yes, again in the early phase. Ozone, probably not. But look at the small particles, PM2.5, early phase and forevermore. So these particles hang in the air for a long time and raise the risk of stroke. So overall, while the strongest association is on the day of exposure, there's also long-term risk from the small particles like PM2.5. So short-term exposure, yes. For some, also long-term exposure is also dangerous. Particles can raise the risk of lung infection. The risk of like you and me, and among the elderly like our parents and grandparents. All of these raise the risk of stroke, both especially 2.5 PM and also 10 by these factors. So clearly particles on the long term, over many, many years, raise the risk of stroke. Up to 25 years, the risk of stroke remains. These small particles do not go away. They are there, they enter the body and cause the risk of stroke and heart disease, and of course, lung diseases. How do these particles risk stroke? One, they cause a systemic vascular stress reaction, and that damages blood vessels. Oxygen radicals are produced, damage endothelium, activate monocytes and other atherogenic processes that cause plaques to form. Thrombus may form, and so can coagulation and platelet factors. Finally, blood flow is affected, and all these factors raise the risk of stroke from acute and I've discussed I've discussed you. Let's now discuss the X factor, relevant to doctors, nurses, therapists. This X factor is about you. What is this? Working for long hours. Because of pandemic, I know you all don't sleep. You're working from morning to night, and this is not good for you. In this meta-analysis of more than 500,000 men and women who have no stroke, they were followed for 7.2 years. If standard hours are, say, 8 hours a day, 40 hours a week, you work from, say, 8 to 5. That's 8 hours a day for 5 days a week. That's normal. If you work more or work less, is it dangerous? Well, here are the studies. They've shown you work longer hours, the risk of stroke goes up in all the various studies. But here's a nice meta-analysis in the next slide. You'll see here that those who work for normal hours or less or more, there's no effect on the heart. But look at the effect on probably okay. Work for 11 hours a day, 5 days a week, the risk of stroke dead. So long hours are not good for you. Every one categorized of stroke rate of hours, raise the risk by 10%. So if you work 11 hours a day, you're going to have the risk of stroke of 33% more than those who work from 8 to 5. So what to do? What can cause this? They believe that this can occur from sudden death. Because you're working so hard, your stress goes up, and this can cause stroke. Also, we work so hard, we have no time to exercise, no time to eat properly, drink too much alcohol, smoke too much. All this raises risk of stroke. Also, we work so hard, we ignore our transient weakness, we ignore our slurred speech, we ignore double diplopia. We take a longer time to go to hospital to seek treatment. Although we are doctors and nurses, we should know better. We do all these things because we work so hard, and we raise our risk of stroke. So what can we do? Please don't work so hard. So therefore, Professor Hung, ladies, gentlemen, stroke is a major cause of death and disability throughout the world, and Vietnam is no exception. There are many well-known risk factors: age, getting older, being male, all that we know. Known risk factors: hypertension, diabetes, cholesterol, all we know. But don't forget the emerging ones, including acute and chronic infection, chronic inflammation, air pollution, and long hours. And these emerging factors must be considered because we now have good treatment for this. We must now address this. But one message to you is please don't work so hard. Please go and rest much as you can to prevent your stroke. With that, I thank you. Thank you very much.
Thank you so much, Dr. Ramani, and very impressed for this report. Because you about the breakfast for course. Because now the COVID-19 pandemic, Dr. Ramani research on the correlation between this COVID-19 and the breakfast about the COVID-19 pandemic.
Yes.
You research on the correlation between this
correlation between COVID infection and stroke.
Oh, yes. Thank you. So important. Yes, you're right. I'm sorry I didn't hear it clearly. My connection is not very good. My fault. Yes, COVID does increase the risk of stroke. It is well known. There are some mechanisms. It somehow causes a procoagulant state or inflammation of vessels and causes large artery thrombosis. So many young people are having large artery occlusion with no obvious cause. It was thought to be cardioembolic, but it may be more than that. So you're right that COVID does raise the risk of stroke, especially large So even those with stroke are also encouraged to take the vaccine. So those on aspirin and other blood thinners we say take the vaccine and press for a longer time to